What's up guys, welcome back to Neurosketch with Dr. Kenny, and today we are approaching patients with extraocular muscle issues. We are approaching patients with dysfunction of the extraocular muscles. This is Neurosketch and welcome back. Let's begin. Patient will never come to you. The patient will never come to you telling you like my superior oblique muscle is not working, or my lateral rectus is not working, or the medial rectus, or anything else. So the patient will come to you with classical presentation of a certain picture that will give you suspicion of something going on, probably with the superior rectus or the superior oblique muscle. And today we are going to take that aspect. We are going to walk in a reverse order from the presentation to the pathology within the muscles or the nerves that will supply those muscles. So before we go into details of the oculomotor pars, trochlear nerve pars, and the abducens pars, let's first see how the patient will come to you. So number one, so the patient will come to you. Most of the patient will come to you, complain of the double vision. A double vision, he sees two objects. He sees, we have one object, for example, and the patient sees two images from the same object. So that is double vision, and we call it diplopia or double vision. So, and most of the time they will tell you like my double vision improves when I'm looking into certain directions. So for example, this boy here, he gets diplopia, he gets double vision when he looks to the left side, of course in the primary gaze as well, but when he looks to the right side, the double vision kind of improving. It improves a little bit, okay? And then some of patients will come to you, some of patients will come to you that they cannot walk downstairs, they fail to walk downstairs, and some of the patient, those are the two common presentation, but common symptoms that the patient will complain. But you can see the patient can intentionally close one eye and then prefers to use the other eye. So that is a sign, that is what you can see from the patient. And of course you can see also some patients who will kind of tilt the head, try to like little bit cheating because of the dysfunction of the extraocular muscles. But you can see also patients, they may have eye misalignment. So we have misalignment of the eyes, this one and this one, they're not looking into the same direction, and so these are the symptoms. These are what the patient will complain about, and then these are what you can see. So some you see the squint or the strabismus deviation of the eyes. You can have, patient can have it like this person here, intentional closure of one eye, because the intentional closure of one eye is trying to the biggest problem here is the double vision. The biggest trouble that they get is double vision. So they are doing their best to try to correct this double vision, and whatever the maneuver they are doing is to correct the double vision. So of course I can just close one eye to correct the double vision, because how do we get the double vision? Of course I understand that the double vision or diplopia, I have discussed it somewhere else separately, but just to a bit of what the double vision is or how is it brought about is by, we have two eyes. The eyes are focusing on same object. So so if we have like one eye is directing one eye is pointing at one object, and the other one is pointing is gazing a little bit away from the point of focus or the point of interest, we get the double vision. We see two objects instead of one object. We have discussed the diplopia somewhere else, but that's a bit of it. Like when the eyes are not aligned properly together in the same direction, we will have a double vision. And how do these patients look? How do these patients see? you try to compress a middle side of your orbit here, and then you see you get something like a double vision, and that's how they see. So it's very, very disturbing. The double vision is very, very disturbing, and they come to you complain of the double vision. Okay, so let's dive now into the oculomotor pulse at the first part of these pathologies, oculomotor pulse. So first of all, we go back to the square one where we discussed about the muscles that were innervated by oculomotor nerve. Remember that all muscles are innervated by oculomotor nerve with the exception of the superior oblique muscle and the lateral rectus muscle. The superior oblique muscle and the lateral rectus muscle. This is the discussion the other time, okay? So because all the muscles are innervated by superior rectus, by the oculomotor nerve, except the superior rectus and the lateral rectus, the superior oblique and the lateral rectus muscle. Superior oblique and lateral rectus muscle. So dysfunction of the oculomotor nerve will result into paralysis of all other muscles except these two muscles. What are the muscles? So the lateral rectus and the superior oblique. Lateral rectus and the superior oblique muscle. But what does the lateral rectus do? The lateral rectus does the abduction. It does the abduction. Okay, correct? Yeah, and then what about so what about the superior rectus? The superior oblique, sorry, we've just discussed the superior oblique. The superior oblique we do intorsion, number one, intorsion, depression, and the abduction. This is easy. You can remember we just discussed the superior oblique muscle. So intorsion, depression, and abduction. Okay, abduction. So we see like all the muscles, all these two muscles will result into abduction. So the abduction, guys. Two, three previous videos I told you like no any single muscle acts alone to bring a desired effect, and this is why I also told you like we have, for example, abduction is done by lateral rectus, by also by the superior oblique muscle. So what does it mean? It means it means that all the muscles in a primary gaze, when you are looking, when your eyes are at ease, and so when your eyes are at ease, all the muscles work together to maintain the position of the eye. Okay, you can always forget about this one. All the muscles work together to maintain the natural position of your eyes. Okay? So under the natural position of your eyes, all of your muscles are involved, all the extraocular muscles are involved. So when we are denervating some of the muscles, the remaining muscle will do their part. Okay? The remaining muscles will do their part so as to maintain the position of the globe. So we have removed all other muscles. We have remained with these two muscles. With these two muscles, where will be the position of the eye? Number one, the position of the eye will be abducted, because all the muscles, all these two muscles, they have abduction. So the eye will be abducted. That is number one. The abduction of the eye will be there. And then what happens as well? What does the superior oblique muscle do? It depresses the eyeball. So the eyeball will be abducted and depressed. Depressed and abducted. But also, because the superior oblique muscle does intorsion as well, so the globe will be depressed, abducted, and medially rotated. Depressed, abducted, and medially rotated. And this is what happens in oculomotor pulse. This is what happens in the oculomotor pulse. And this gives the impression of down and out position of the eye at rest. At rest, it means that under natural position of the eye would be maintained by all muscles to be like perfectly looking forward, like natural position. But when we are removing all other muscles remaining in these two muscles, their action is to drop the eyeball, to laterally rotate, and to drop the eyeball, to abduct, and the medial rotate. Because the lateral rectus does the abduction, also the superior oblique does the abduction. So the eye will be abducted. Superior oblique muscle will depress the eyeball. The eyeball will be depressed, and then it also medially rotates the I think you can all remember. So the down and out position of the eye is a classical presentation of oculomotor pulse. In other words, if you go to the exam, if you're going to the exams and then you see you are reading a clinical scenario and you see the eye is down and out, you definitely go for oculomotor nerve. There is no discussion about that. You don't need even to read the other part of the question. You have to read the other part of the question. It could be except, but whenever you see the down and out, that's a typical presentation of oculomotor pulse. How it together? How is down and out brought about is by the action of these two muscles, the lateral rectus muscle and the superior oblique muscle. But oculomotor nerve, it has innervated all other nerves, all other muscles. So what are the other muscles? So do you remember the levator palpebral superioris? This is classical presentation. The eyelid, the eyeball will be down and out. So down and out is classical presentation. The classical presentation of oculomotor pulse. So what about the levator palpebral superioris muscle? The levator palpebral superioris muscle was innervated by oculomotor nerve. So what does the levator palpebral superioris muscle do? The levator palpebral superioris muscle was doing the chief elevator of the eyelid. The chief elevator of the eyelid. And what if we are removing the chief elevator? We are removing the action of the chief elevator of the eyelid. The eyelid will drop. Will it be complete or incomplete? It will be complete, because this one is the strongest muscle, the strongest elevator, because the superior tarsus muscle was the weak elevator, and it was depending on the action of the levator palpebral superioris, because the levator palpebral superioris was the one that initiated the elevation, and then the superior tarsus was maintaining the state of elevation. So in case of removing the oculomotor part, it will also denervate the levator palpebral superioris, and then it will result into complete ptosis. And the superior tarsus muscle, we said, is incomplete, as in Horner's syndrome, for example. But under the oculomotor pulse, we have complete dropping of the upper lid. So the patient can never ever open the eye unless he uses the manual. It does manual elevation, so he can only elevate by using the finger. Otherwise, you will never ever elevate. So that's another thing that you have, the classical presentation of oculomotor pulse. So are we done with the oculomotor nerve already? Are we done with the oculomotor nerve already? No, if you said yes, of course you have completely forgotten about the pupils. Because what did we say about the pupillary reaction? The size of the pupil. The size of the pupil was controlled by parasympathetic and the sympathetic nervous system. The sympathetic was for dilatation, the parasympathetic was for constriction. And the parasympathetic was getting into the eye by the way of oculomotor nerve. See, one more time again, we are seeing the pupillary reaction, and I don't know if I can emphasize more about how important pupillary reaction is when you are talking about vision. Every now and then you'll be seeing the pupillary reaction, and I'm glad that I did it already. Otherwise, it would be like miserable at this time. Okay, so the constrictor pupillae is also controlled by the parasympathetic nervous system, and the parasympathetic was getting access to the eye by the way of the oculomotor nerve, preganglionic parasympathetic by the way of oculomotor nerve. So if we are removing the oculomotor nerve, means we are taking out the parasympathetic, and the eye will remain dilated. Why do we have a dilated pupil? Because we have removed the parasympathetic, because At a normal state, I've told you the other time, at a normal state, the pupil, the size of the pupil is maintained by the two systems, and that is parasympathetic and the sympathetic nervous system. But we are removing the sympathetic, we are removing the parasympathetic at this time, and so we are remaining with the sympathetic. And what the action of the sympathetic is dilatation of the pupil, is dilatation of the pupil. So. So this is the classical picture, of the oculomotor palsy or oculomotor nerve injury or palsy. So now let's take together these symptoms. So let's take together. You will say that in under oculomotor nerve, the eyes will always be down and out, down and out. We have a complete ptosis and the pupillary dilatation. So that is it about oculomotor palsy. You can never ever forget about this one. And then next to it will be the trochlear nerve. Don't forget to follow the discussion of the trochlear nerve. And if you haven't subscribed, this is the only way we keep in touch. And so subscribe, stay tuned, stay curious, and see you next time.